Now we've got an awesome panel. It's a time for our panel of experts. My good friend, Dr. Georges Benjamin, is the executive director of the American Public Health Association. Dr. Donna Christensen, a former member of Congress. She was the doctor before anybody was up there, first African-American doctor in Congress, and want to tip our hat to that. And now there are just so many doctors up there, a dime a dozen, but she was up there early. Former member of Congress who serves as a public health advisor to the Virgin Islands Department of Health, also a board member of Consumers for Quality Care, the sponsor of today's event. And Dr. Jalpa Doshi is a professor of medicine at the University of Pennsylvania. She's also the director of the Value-Based Insurance Design Initiatives, so important, at the Center for Health Incentives. And Samantha Artiga is the vice president and director of Racial Equity and Health Policy at the Kaiser Family Foundation. Big mouthful, everybody. Great to see all of you. Let me start out with Donna Christensen. Great to have you here. And I know that later we have Robin Kelly, who's going to be up there. And I know that you both kind of led the Health Brain Trust in the Congressional Black Caucus, which I think is such an important role. So as we think about expanding healthcare, expanding access to health insurance, and getting people onto a positive and constructive health track and addressing these inequities, Donna, what are the key pieces of that framing that are missing today that we really need to discuss? I think you're muted. There we go.
To address the inequities, you really need to address access and affordability.
Right.
And access means that for access, there are many barriers to getting the kind of care. There are barriers when you get in to the healthcare system because of the racism and the bias that exists there. Those need to be addressed. And then affordability. We've had so many changes, for example, to Medicaid, where caps, where individuals are dropped from the Medicaid rolls, benefits are cut. So we have to make sure that at least for that program, that it is expanded and we get rid of some of those barriers that have prevented people from being covered. We need to make sure that we address the exchanges. A lot of individuals who lost coverage went on Medicaid or went on the exchanges, but the cost is still too high. So we need to adjust some of the subsidies to ensure that we're really meeting the needs of people. So we need to make sure that there are providers there, access to providers, that those providers are of the community, that are humble and understand the community, and really we need to have more underrepresented minorities in the health professions. We need to utilize community leadership to connect people to healthcare. There are so many issues, but we also have to address the circumstances under which people live. If we don't change racism, and if we don't change the social, the economic, the environmental determinants of health, a lot of the work that would be done to provide access and to provide coverage would not be as effective.
I really appreciate you talking about the volume of challenges that are out there. I mean, it is a huge lift, and I think you're addressing it very directly. Georges, we've talked about this many times, and I would, just building off what Donna Christensen said, you and I have talked about parts of greater Baltimore where you can go from one zip code to another zip code, and you've got, 20 years difference in life expectancy in a very little period of time. And so when you look at the structural elements of that, I mean, you've been at this, we've been friends for a long time. I just ask you, we're at a political inflection point in this country. Should we be talking about changing or revising the social contract around health and the patient? And what would be the key pieces of that for you?
Yeah, I think that we need to do this. As you, Steve, as you know, I practiced emergency medicine the first half of my clinical career, and then I pivoted into public health. And one of the things that I learned is that we are very, very good at putting people back together after they've injured themselves or gotten a very severe disease. But it's very costly at an enormous human cost. But we don't spend enough effort on the front end in terms of addressing those societal conditions in which people live. And the Congresswoman pointed out very clearly, and she's always going to be the Congresswoman to me, very clearly, about the issues around the social determinants of health. You know, if you think about how it played out in this terrible pandemic that we have, it was in many cases the lack of infrastructure in communities that's even today preventing us from adequately vaccinating individuals. It's the lack of providers in rural communities. It's the lack of education and knowledge. We call it health literacy, really understanding the healthcare in a culturally competent way. It's the fact that we have a system that does not have everyone in and nobody out. Even having that get in the system card, we all call that an insurance card, is extraordinarily important, because even when you give the vaccine as an example, or some of the therapies as an example for COVID, it doesn't guarantee that you're going to be able to get healthcare, because going to the doctor still requires some cost. And so we really need to think about the social compact in a bunch of ways around income inequality, on housing, transportation, access to energy. Look, the challenges that our colleagues and friends that live in the state of Texas today, look at the fact that they really haven't invested in the energy infrastructure, and what's that done to its health. And if you really think about it, what they're not talking enough about is the disparities that's occurring in Texas, because there are people right now that were able to get up and go to a hotel. There are people that were able to get up and go to another place. And there's some folks who lived in communities where they're living in their car, where they're just using blankets to keep warm because of the loss of energy in that community. What would have happened had we invested in a strong energy security in the state of Texas? The health outcomes those folks are having right now would not be there in place. And the disparities that we're going to see as we begin to measure them, in a couple of days from now, hopefully when things heat up, are going to be, and we're terrible. And by the way, it was all preventable.
Yeah.
Powerful. Dr. Doshi, I know that you work around insurance programs and look at value-based outcomes, which I find such a promising and fascinating, track. But when you look at that and you're trying to design those initiatives, I guess I have two questions of that. One part is, how do you bring in the population that George's and Donna Christensen have been talking about into those programs so that they are included in part of that? And I got to tell you, the other dimension, I do a lot of healthcare moderating of, programs moderating. It's confusing to me, and I'm pretty well read. I mean, I'm just interested in the literacy demands for people that are not part of the health tracks that we need to bring in. What do we need to create, greater connectivity between patients in need and the healthcare system?
Yeah, sure. And so the most of the work that I do is in the context of prescription drug benefit design.
Right.
And I can tell you that we've seen from a lot of experience with, for instance, Medicare Part D, Steve, where Medicare beneficiaries really struggled when the Part D benefit was put into place, and the number of options that were being offered in terms of how do you go about choosing and picking the right options. And the type of populations that George and Donna were talking about, they clearly struggled much more in terms of making choices and evaluating which drug plans, formularies cover all the drugs that I need.
Right.
Which drug plans, formularies have the drugs that I need, but at a lower cost sharing that will cost, have lower out-of-pocket costs for me. And I think that this is an ongoing struggle within our fragmented healthcare system, where we don't have one single payer that has a single set of policies. And so it's patients who struggle trying to figure out. And as what I can also tell you, given all my work at the Center for Health Incentives and Behavioral Economics, is that human behavior tends to just stick with the status quo. So we have a lot of patients who are still continuing to stay in their plans that are probably not ideal for them. But if there's too much of a cost, and I don't mean a monetary cost, but just a cost in terms of a search cost in trying to find out the best plan.
Do you see, Dr. Doshi, any model out there that's particular promising? I mean, this issue of how do you minimize and lower out-of-pocket costs. I've talked to Representative Doris Matsui about this at least 8 times. You know, it's such, what you just talked about, Medicare D, the donut hole, the relationship with insurers and how to decomplexify that has been, you know, an automatic part of these conversations for so long. But do you see any best and promising practices that you think we should highlight here today?
Absolutely. I think, as we just heard, even in the survey that was shown by the Consumer for Quality Care survey, the idea is that we are living in a system where we have patients who are facing really high deductibles. They're increasingly facing co-insurance as opposed to fixed co-payments. That means they're directly being subject to the percentage of the price of the service, or in the case of what I'd researched, the drugs that they're looking to get access to. And what we see is that there is a lot of barriers, particularly for Medicare Part D patients, because this is the population, the only insured population that does not have out-of-pocket maximum. Even the health insurance exchanges under the Affordable Care Act have this type of protection for all its enrollees. But under Part D, or even under Medicare Part A and B, we are exposing our nation's seniors and individuals who are disabled to just unending, never-ending out-of-pocket costs. I think the low-hanging fruit here that I'd like to highlight today is the fact that there is an opportunity where Congress can act, and there has already been legislation that has been considered, and I believe 3 bills in Congress that were introduced in 2019 that have talked about introducing out-of-pocket maximum caps for the Part D patients. What I'd like to highlight, though, is that it's not going to be sufficient to just put in an annual out-of-pocket maximum. And this actually applies even for the non-Medicare, privately insured population, be it an employer-sponsored insurance plans or under health exchanges. Because that we have a system right now, as I mentioned, where we have patients who either face really high deductibles in the privately insured sector and the health insurance exchanges, and under Part D and other segments where they're being subject to co-insurance, what we are seeing is that patients are being subject to cost sharing that's like a roller coaster ride. And essentially, they face really high costs at the beginning of the year. The non-Medicare population who is fortunate enough to have out-of-pocket maximums will ultimately reach it and then kind of stop paying anything out of pocket. But the Medicare population is on this never-ending roller coaster, right? Because these benefits reset on January 1st.
Right.
And so I think we also need to pay attention not only to the amount of out-of-pocket costs that patients are paying, but the timing of it. And what we really need as an option which smooths out these costs for these patients, akin to what the energy companies do, helping consumers with payment options to smooth out high winter heating bills.
There is a lot packed in that. I'm really grateful for that outline of some avenues we can do it. Samantha Artiga, you are one of my favorite places. I love Kaiser Family Foundation. I read your products. I try to tool up when we're doing programs around this, and you deal with racial equity questions. You know, when I listen to Donna Christensen and my friend Georges Benjamin and how endemic these problems have been for so long, you know, it is one of these things where I ask, and I worked for Jeff Bingaman, a senator in the 1990s in the United States Senate. At that point, when it came to health care coverage, we had already done 13 major health care reform bills. But when you looked at the number of uncovered Americans in the 1990s, that you looked at the communities that were left out and marginalized, and this is 20 years ago. I guess my question is, we have the Affordable Care Act, but why? I guess my question is, you're obsessed with this topic. I'm just interested in why is it so hard to get it right in terms of getting all communities covered under a health umbrella? And what would you put on the table? You're at a smart foundation. What would you do?
So I think I'm going to be echoing a lot of the comments that we've already heard from the esteemed panelists that went in front of me. I mean, we know that health inequities have existed for years. They were in place long before the pandemic. The pandemic has really shone a bright light on those disparities, made more people aware of them, and is deepening them. And we are really at a very important point in time to address these disparities to prevent against even further widening going forward due to the pandemic. Certainly, health coverage is one component of the disparities we see in health and healthcare. The Affordable Care Act helped increase coverage across groups, but still, even with those coverage gains under the ACA, we see that people of color remain more likely to be uninsured, and that those gaps are likely widening as a result of the pandemic in terms of what we understand about trends and who's losing jobs and who's losing health coverage. There are a number of proposals at play now to expand coverage and make coverage more affordable, including some provisions in the Relief Act that would create incentives for some of the still holdout states to expand Medicaid to make the ACA coverage more affordable. And closing that coverage gap is going to be one really important component. But as my colleagues mentioned at the outset, the coverage is just one piece, and it's not enough. There is ongoing racism and discrimination in the healthcare experience that affects health outcomes. There's a large body of research that shows people of color receive poor quality of care. There are also access barriers that extend beyond health coverage, things like transportation, where providers are located, people's working and caregiving schedules. And then there are the broader social and economic factors that really drive our health. So we cannot fully address health inequities without also really doing the hard work of addressing inequities in these other areas like food, housing, transportation. So it's a big job, that it's cross-sector. It needs a long-term commitment with a broad focus.
Well, I really appreciate the way you framed it, Samantha, because that is, when I talk about whether or not, I often wonder, are we at an FDR moment where, is an opportunity in this crisis to reframe the social contract for more Americans? It raises the question. Just very quickly, because I do want to go to a question, I want to go to Donna and to George's and ask you. Donna, you tweeted recently, we don't have to make this partisan, but you said Republicans often refuse to make the significant and most effective investments needed in the care picture, in the health picture. Let me just ask you both, what are some of those investments that you think are vital for us to talk about today? Let me start with Donna and then go to George's, and then we'll take a question.
Let me talk about one investment that was included in a provision that was included in the Affordable Care Act that was never really funded. There was several, and it has caused a lot of hardship that could have been prevented. One of them was to improve and strengthen the public health infrastructure in this country. And it was never really funded to the extent that it needed to be. The community health worker grants, there was so many other programs that could have been funded. And so that's one.
But let me interrupt you, Donna. Let me interrupt you. Do you think because of the pandemic and what we're seeing, do you think there's a chance now to go back to those authorizations and get them funded now? Because I've heard from so many people what wobbly state our public health infrastructure was in. Do you think this pandemic changes the game on that, or are you pessimistic?
I sure hope so. No, I'm not pessimistic. I think the light that this pandemic has shown on the inequities and the weakness in our public health infrastructure compels the Congress and the Biden-Harris administration to really begin to address it. We used to talk about global health security and making sure that other countries had their public health infrastructure in place, and we really have neglected ours.
Georges, your thoughts on investment in putting the patient first?
Yeah, I would ditto the public health infrastructure for sure. But let me just say, I think at the end of the day, We got to build a system with everyone in and nobody out, and we have to make it affordable. One of the many ways we can also make this affordable is by making sure that we get to the minimum wage and get to a wage that can everyone that can work and not be in poverty. There's a strong correlation between poverty and poor health. And it is so strong that if we reverse that, it would make a tremendous difference in our ability to be affordable. Now, we can't make it regressive. In other words, we can't make all that money then go into a healthcare cost structure that's out of control, which our healthcare cost structure is out of control. But I do think that at the end of the day, making sure that everybody was in effect a living wage, and I know that's different from a minimum wage, is going to be very, very important.
Well, look, I mean, each one of you, I think, has done a very good job of talking about the synergy between these different factors and how you kind of address both inclusion, but the real costs, as you know, Dr. Doshi just shared, as you all have shared. Let's take a question now. We have a question from Amy. Amy?
I'm Amy Niles, Executive Vice President with the Patient Access Network Foundation in Washington, D.C. We worry about the rising out-of-pocket costs for prescription medications, especially for Medicare beneficiaries who are living with chronic illnesses. What are the Medicare Part D policy solutions that could help lower these costs?
Let's do a round. Let me just start with Dr. Doshi for that. Dr. Doshi?
I think there are several options on the table. As I already mentioned, clearly the first lowest hanging fruit that Congress must act on should be instituting a maximum out-of-pocket limit for Medicare beneficiaries under Part D. The costs that patients with chronic illnesses and serious life-threatening diseases which need to be treated with expensive specialty medications result in too much of an out-of-pocket burden. But the second piece is that given the Medicare Part D design, this too much out-of-pocket burden also happens to occur too soon at the beginning of the year. So a cancer patient who needs an oral anti-cancer medication with $10,000 in total out-of-pocket costs in the year would have to pay $3,000 for their very first prescription. So clearly, Congress needs to do something to allow smoothing out these costs for these patients who are typically on fixed monthly incomes. And these costs for single prescriptions, not just for cancer, but for MS or RA drugs are sometimes one and a half, two-folds, three-folds of the average Social Security income. The third option, which I think would also address some of the inequities that we've been talking about here, could be to be more nuanced and not treat all patients alike. And current bills that were floated around in the Congress around annual out-of-pocket maximums had a single limit. But let's think about income-based annual out-of-pocket maximum limits. Let's think about income-based monthly out-of-pocket limits. Fourth, I think for specialty drugs, we could potentially consider not requiring all drugs that CMS does right now that exceeds a certain threshold, about $700, to be placed on these really high cost sharing tiers called specialty tiers. And perhaps cost sharing should be tied to the value of the drug that the drug provides, as opposed to just having a high cost sharing applied to all these really important medications that might be necessary for many of these patients.
Terrific, thank you. We have, we're almost out of time, but quick thoughts, Samantha Artiga and Donna Christensen and Georges Benjamin. Samantha?
Well, the past administration expanded on the copay adjustment so that the copay coupons don't count towards the deductible, and I think that's a real low-hanging fruit that needs to be corrected as well, that might help to reduce the cost.
Terrific, thank you. Samantha? Do we have some?
I don't have anything specific to add other than to just, reinforce that costs and out-of-pocket costs really impact people's ability to access care. And we know from the research that low-income people in particular are very sensitive to out-of-pocket costs, and that
Right.
it has real impacts on whether people are getting the care and services they need.
Really appreciate that. I'm going to give the final word to George. George?
Yeah, look, at the end of the day, if we're really serious about controlling costs, then we need to start looking at some new models like we have in Maryland, the state of Maryland, our all-payer system in Maryland, or frankly, doing more around letting the federal government negotiate within some limits for prescription drugs. At the end of the day, the cost of all of our care, particularly pharmaceuticals, is way too high. And if you don't pay for your medication, then we always pay for it in someplace else. And we just don't ever capture those costs.
Well, look, it's been a fascinating conversation. One of these days, I don't know if you remember the old Fred Friendly seminars. Fred Friendly would be on there, and they'd have U.S. government officials oftentimes saying, it was about dealing with nuclear war, but they would have different agencies represented. I want to someday be the host of that with everyone in healthcare, the insurers, the pharmaceutical firms, the public health associations, the patient advocates, the Kaiser Family Foundation, everybody, and simulate a way to eventually address some of these inequities. And I hope you'll all come back when I get the chance to do that. It's been a real pleasure to talk to all of you.
Thank you, Steve.
Thanks.